আজকের আমাদের সেশনটি হচ্ছে ইভালুয়েশন অফ দ্য চেস্ট পেইন এবং আজকের সেশনে আমাদের রিসোর্স পারসন এবং গেস্ট অফ অনার হিসেবে আমাদের মাঝখানে উপস্থিত আছেন প্রফেসর ডক্টর মোহাম্মদ তৌফিকুর রহমান স্যার। স্যার বর্তমানে কর্মরত আছেন অধ্যাপক এবং বিভাগীয় প্রধান হিসেবে কর্নেল মালিক মেডিকেল কলেজ হসপিটালে। আপনাদের যদি কোনো প্রশ্ন থেকে থাকে সেটি আমাদেরকে কমেন্টস করে জানাতে পারেন এবং স্যারের কোন ক্লাসগুলো আপনারা পরবর্তীতে করতে চাচ্ছেন এবং করতে আগ্রহী সেটি আমাদেরকে কমেন্টস করে জানাতে পারেন। আশা করি আমাদের সঙ্গেই থাকবেন। ধন্যবাদ সবাইকে। স্যার আপনি শুরু করতে পারেন প্লিজ।
Thank you, Dr. Tariq Kamal, for nice introduction. Now, today we'll discuss on evaluation of chest pain, and it should be actually on a case-based approach to the chest pain. We all know that there are different causes of chest pain. There are a lot of causes actually of chest pain. There may be some cardiac causes, there may be some non-cardiac causes also. So chest pain is not only due to cardiac causes only. The chest pain may occur due to non-cardiac causes also. So how will approach when a patient came with chest pain to our chamber, or when a patient came with the emergency department of a hospital, or when a patient come to the outdoor department? So how will approach if a patient come with chest pain? So we'll discuss it today. Here we see that there are several structures around the chest. So if a organ is affected or diseased, so chest pain may occur due to any abnormalities of that organ. Here we see that there is a heart in the center of the chest, and there is pericardium also around the heart. And there are some great vessels arising from the heart, like aorta, or there are some vessels, pulmonary arteries. So if they are affected, patient may have chest pain also. So and on the two sides of the heart, we'll see that the lungs and lungs coverings, that is pleura. So if there is a pathology in the lung, like pneumonia or pericardial effusion or pneumothorax, or if there is a pathology in the pleural space, so patient may have chest pain also. If we see the retrocardiac structures like esophagus or in the trachea, if there is any pathology like reflux esophagitis or tracheitis, patient may have chest pain also. So below the heart, there is a diaphragm. So if there is a pathology in the diaphragm, patient may have also some chest pain. And below the diaphragm, there is the abdomen, some upper abdominal organs like stomach, there is a liver, there is a pancreas, and also there is a gallbladder. If there is a gallbladder pathology like cholecystitis or cholelithiasis, that is gallbladder stone, or there is any pathology in the liver, there may be some liver abscess, or there is a hepatitis also, or there is any causes that can cause the hepatomegaly, or if there is a pancreatitis, patient may have also some chest pain, or if there is a stomach pathology like peptic ulcer disease, or like cancer, or any neoplasm in the stomach, patient may have also some chest pain. And overlying the structures, that is viscera, like heart, lungs, there is overlying structures like ribs, there is a muscles, and over the ribs and muscles there is a skin. So if this skin is involved, but there is a pathology in the skin, and so patient may have also some chest pain, or there is a trauma to the ribs, or there is a trauma to the muscles, or there is a muscular disease that can affect the muscles overlying the chest, patient may have chest pain also. So when a patient with chest pain, so we have to evaluate, we have to have some ask some questions to confirm that is where the pathology actually lies. So if we see the one first case scenario, that is a 65 years old hypertensive smoker, diabetic, dyslipidemic man with central chest tightness on exertion for the last 1 month. And his pulse tachycardic, his hypertensive, his diabetes is uncontrolled, ECG was normal. So what should be his next investigation? What was the probable cause of his chest tightness? In that cases, we know that the patient age is 65 years, and patient have some risk factors like hypertension, smoking, diabetes, and dyslipidemia. And patient complain of central chest pain with these risk factors, and the chest pain usually increases on exertion. So from this history and investigation findings, though the patient ECG is normal, but probably this patient pathology is in the chronic stable angina. We will see that this diagnosis should be the chronic stable angina. And the investigation next, actually, we should do, though the patient ECG is normal, their echocardiography may be also normal, but this patient should undergo ETT, that's the exercise tolerance test, and there may be some pathology in the exercise tolerance test may have. And even if ETT is positive in the low threshold, that is patient ETT is positive first stage or second stage, then the patient should undergo coronary angiogram, and patient may have some coronary atherosclerotic disease also, we can get actually. So this is the features, actually the scenario of the chronic stable angina. And if we shift to the next case scenario, that is 55 years old, hypertensive smoker, diabetic, that dyslipidemia, that is, this patient also got some risk factors like hypertension, smoking, diabetes, and dyslipidemia. Actually, these are the risk factors for atherosclerotic cardiovascular disease. And also this patient present with chest tightness, as well as patient has excessive sweating that lasts for more than 30 minutes. And this chest pain is not relieved by taking sublingual nitrates. And his pulse is 104 per beats per minute, blood pressure is uncontrolled, and diabetes is uncontrolled. But ECG now showed some ST segment elevation from the V1 to V6, that is, there is ST segment elevation in the chest lead. So what is the probable cause of his chest tightness? So this, in these cases, the diagnosis, as there is ST elevation in the chest lead, and this patient has got risk factors, and the patient is diabetes, his hypertension is uncontrolled, and as this patient has got central chest pain, and this chest pain is actually occurs in rest, and this pain is not relieved by taking sublingual nitrates, even it persists more than 30 minutes. So this is actually the case scenario of the a patient with acute coronary syndrome, that is acute ST elevated MI. That is, the patient has acute ST elevated MI, and this is the features of acute coronary syndrome. As we know that acute coronary syndrome includes, there may be ST elevation MI, there may be non-ST elevated MI, and there may be unstable angina. These are the three subclasses or three presentations may have with a patient with acute coronary syndrome. So this scenario suggests that the patient actually has acute coronary syndrome in the form of ST segment elevated MI, that is anterior MI. And this is also a case that is the patient has 32 years old, but he is a smoker with central chest pain for the last 5 days with fever. In that cases, the patient has got central chest pain with fever. Pulse was 120 beats per minute. Blood pressure is 140, 195 millimeter mercury. And there is also ST segment elevation in the chest lead, as well as there is a ST elevation in the limb lead. The inferior lead also lead to 3 AVF. There is a widespread ST segment elevation in anterior and some other leads also. So what was the probable cause of his chest pain actually? As this patient is young and this patient has got only one risk factors like smoking, and this patient has got chest pain, as well as this patient along with this chest pain, patient has got also fever. So this patient, though the patient has ST segment elevation, so there is a confusion with the ST segment elevation MI. And as there is a confusion of the ST segment elevation MI, but here we see that there is a widespread ST segment elevation, and there is a no actually localized, but that suggests the local involvement of the coronary artery. So actually this is the case of, as there is patient has got also fever and the patient is young, the patient has got one risk factor, this is smoking. So in that cases, actually this scenario suggests the patient actually has acute pericarditis. and this is the scenario of the acute pericarditis. So here you see that chest pain may occur not only due to cardiac causes, that is acute coronary syndrome or chronic stable angina. Patient may also due to cardiac cause, but not for coronary cause actually. This is the acute pericarditis is the cardiac cause of the chest pain, but this is the non-coronary cause. If the patient has got stable angina or patient has got ST elevation to MI or acute coronary syndrome, these are the actually a cardiac cause as well as this is the coronary cause also of the chest pain. But here there is a cardiac cause, that is this pain arises from the acute pericarditis, but this pain is not arises from the coronary cause. There is no coronary pathology. So this is the non-coronary cardiac chest pain actually. So there may be some non-cardiac causes also, as we have already discussed in the first slide. That is a 42 years old smoker gentleman from Russia, present with central chest pain that lasts for 35 days, and his chest pain actually increases at the night when a patient taking rest by lying flat actually, and this his pain by that is a burning sensation in the chest that is relieved by taking usually taking antacid. And his pulse was 80 beats per minute, BP 130 over 80 millimeter mercury, and this is the completely normal. So here, what are the probable cause of chest pain? As this patient is 42 years old, and that is a smoker also. We all know that smoking is also risk factor for reflex esophagitis also, that aggravates the reflex esophagitis. As the patient of though the patient has central chest pain, and the patient is 42 years old, but the patient persists more than 35 days, and his pain actually increased when the patient is lying flat. So actually this occurs due to the reflex esophagitis also. So in that cases, the cause is reflex esophagitis, and this is actually the non-cardiac causes of chest pain. That is the non-coronary, non-cardiac type of chest pain. There may be some other causes of chest pain, like any that pain arises not due to from any structural heart disease or structural any within the chest or within the abdomen also. So this is actually functional causes of chest pain may occur. 20 years old, a lady presented with central chest pain with palpitation for the last 5 months. Her pulse was 110 beats per minute, blood pressure of 120 by 80 millimeter mercury. But each ECG showed several, normal for the several times, and echocardiogram also showed a normal study. And ETT done previously for the 2 times, but ETT was also negative in the last 2 episodes also. So what are the probable cause of his chest pain? As this patient, ECG is normal, echocardiography normal, even ETT, that is ECG on exertion is also normal. Patient is a young patient, that is only 22 years old lady, and patient has got palpitations as well as chest pain. So what should be the causes of the chest pain of this young lady? This is actually functional causes of chest pain. Actually, this chest pain not arising from the heart or not arising from the any other structures like lungs or pleura or any diaphragm or any organ, abdominal or upper abdominal organ like stomach or pancreas or gallbladder or liver. So what are the actually the cause of this patient's chest pain? That is the generalized anxiety disorder. In that cases, the cause of chest pain is the functional, that is the generalized anxiety disorder. Here we see that there is another case scenario that is a 25 years old lady presented with the central chest heaviness with palpitations with low-grade fever for the last 2 months. That is the patient present with central chest heaviness with low-grade fever for the last 2 months. Pulse was 110 beats per minute, blood pressure 110 over 70 millimeter mercury. ECG showed low voltage ECG, and echocardiography showed there is a echo-free space in the pericardium. So what was the probable cause of his chest pain actually? As the patient has got low-grade fever patient has got central chest tightness with palpitations, with low-grade fever for the long duration, like 2 months. Actually, in that cases, what should come at first in our mind, as the patient has a low-grade fever, so this patient may have the tuberculosis. So tuberculosis should be the first consideration in the context of our country, as the tuberculosis is very much common in our country. So these low-grade fever for the long duration, like 2 months, this may be due to the tuberculosis. So, but what the tuberculosis affects, or which organ is now affected here by the tuberculosis, as this patient has got central chest heaviness along with palpitations, and the patient also ECG, low voltage ECG, and there is echocardiography shows there is echo free space, that is there is a pericardial effusion, and that causes the low voltage ECG, and in echocardiography we found there is a echo free space in the pericardium. So this is actually the tuberculosis diagnosis, tuberculosis pericardial effusion. That is the diagnosis pericardial effusion, and what are the cause? In that case, is actually this cause may be probably due to the tuberculosis. So this is the tuberculosis pericardial effusion actually. So pericardial effusion can cause the chest heaviness or chest tightness, but we should actually elicit the proper history. We should take the proper history, as well as we should examine the patient carefully, and we should do the relevant investigation to confirm the diagnosis actually. What are the causes of chest pain in a patient? Here we see that there are a lot of causes of chest pain here. That is maybe cardiac chest pain, that is maybe chronic stable angina or unstable angina or myocardial infarction, or there is a pericarditis. There may be some vascular causes like aortic dissection, pulmonary embolism, or pulmonary hypertension. There is a pulmonary cause, that is a lung cause. There is a pleuritis, a pneumonia, trachobronchitis or pneumothorax can cause the chest pain. And in that cases, usually one lung, if there is a one lung involvement, so there should be unilateral chest pain actually. There may be gastrointestinal causes. There may be GERD, that is gastroesophageal reflux disease, peptic ulcer disease. There may be cholecystitis, or there may be pancreas involvement, and pancreatitis can cause the chest pain actually. And the patient may also have some musculoskeletal pain like costochondritis. There may be trauma or a strain, and there may be infections on the skin like herpes zoster. This, if herpes is involved in the skin, so there may be severe chest pain, severe type of chest pain patient may experience if a patient is suffering from the herpes zoster. And there may be psychological causes. We already discussed from a case scenario, a young lady, 22 years old, with chest pain, the ECG, echocardiography, NET normal. So there may be some psychological or functional case also. That is maybe due to panic or depression or that anxiety disorder. There is a skin and soft tissue lesion like fibromyalgia, or there may be lesions or tumors that involve the skin or that involve the muscles, or there may be trauma to the chest wall that may causes the rib fracture that can cause the chest pain also. So this is the actually different or several causes of chest pain. So here we see that there's cardiovascular cause, pulmonary cause, gastroesophageal cause, chest wall cause, and there may be some pediatric causes also. And these are life-threatening causes of chest pain. Actually, it's the acute coronary syndrome in the form of the unstable angina, non-still MI, or still MI. There may be aortic dissection, there may be pulmonary embolism, pneumothorax, tension pneumothorax, pericardial tamponade, even mediastinal, and there is esophageal rupture that can causes the life-threatening acute causes of chest pain actually. So chest pain may be due to cardiac, or there may be non-cardiac. And within the cardiac, patient may have coronary cause or non-coronary cause, that is ischemic or maybe non-ischemic. And there are some non-cardiac causes. There is a lot of structures may causes the chest pain. So there is a lot of causes of non-cardiac chest pain like gastrointestinal cause and non-gastrointestinal cause, or pulmonary cause, or maybe psychological cause. So there may be a lot of chest pain actually a patient may have. So this is the cardiac non-ischemic and cardiac ischemic or non-cardiac causes of chest pain actually. So when a patient come with chest pain, or actually how we should get the history from the patient. So we have to have some questions like patient have to ask some questions like location of the chest pain. Actually, usually we know that cardiac chest pain usually central in location or retrosternal or diffuse location. But non-cardiac chest pain is usually peripheral, that is unilateral, maybe unilateral, but usually it's localized chest pain. And there may be radiation in case of chest pain. Patient, in case of cardiac chest pain, this chest pain may be radiated even to the different ways, like patient may be in the left arm or right arm, in the throat, or patient the chest pain may be radiated also in the back. But in case of non-cardiac chest pain, usually there is no radiation actually occur. And when we see the characteristics of the chest pain, usually in case of cardiac chest pain or ischemic cardiac chest pain, the chest pain is usually tight. There is a squeezing, or there is compressive type of chest pain, or there may be choking type of chest pain. But in case of non-cardiac chest pain, patient, it may be sharp, there may be stabbing in nature, or there may be catching in nature. How actually this chest pain occurs or precipitates or increases, that's sort of the factor that increases the ischemic type of chest pain, ischemic cardiac chest pain. That is this precipitated by exertion or emotion in case of cardiac chest pain. But in non-cardiac chest pain, usually that is spontaneous or non-related to the actually any posture or an exertion, and that is no relation with the respiration or palpitation also. How the chest pain usually relieved in case of cardiac chest pain, usually it is relieved by taking rest or by giving the sublingual nitrates. But in case of non-cardiac chest pain, there when patient takes rest, the chest pain usually not relieved by rest or slow or non-responsive to the nitrates. There may be some associated features. If there is a cardiac chest pain, there may be associated sweating or breathlessness may have patient. But in non-cardiac chest pain, so that associated features lies according to the structure from where the pathology lies or from where the chest pain arises. That is, if there is a gastrointestinal, so the other feature should be gastrointestinal. If the respiratory, so other feature should be respiratory. And the psychological, so patient may have some psychological history should be elicited. So this is the way actually we have to get history if a patient come with the chest pain. So from these characteristics or from this history, we can differentiate from the causes of cardiac chest pain from the non-cardiac chest pain, and actually. So actually, this is the way we can actually evaluate if a patient came with the chest pain. And so evaluation by the history, evaluation by the examination findings, and we can also evaluate by the investigation some. So we can do the some investigations like to see the risk factors if a patient have or not. So we can do the blood sugar test, we can do the lipid profile also, and we can see the investigation to see if there is any other causes or not. So we can also do the homocysteine level or CRP level also. These are actually risk factors. And to confirm the diagnosis of the cardiac chest pain, actually, we should do ECG, echocardiography, exercise tolerance test, or angiogram may be needed in terms of the CT coronary angiogram, or conventional angiogram may be needed, or even patient has some other test like CT or some other test like MRI may be needed in some cases to have some structural diseases to confirm the causes of chest pain actually. And so we have to confirm to find out the cause of chest pain. So we have to do some investigations that may help us to differentiate what is the cause of the chest pain actually. And from when we establish a diagnosis, then we have to treat. So if the patient has ischemic type of chest pain, so we need the anti-ischemic therapy proper anti-ischemic therapy. If the patient has acute coronary syndrome, in that case, the patient should be admitted to the hospital, CCU actually, and the patient should be treated as well. Like patient may need intravenous nitrates, even patient may need anticoagulants, or patient may need thrombolytics also if the patient has still elevated MI if the patient has still elevated MI. And if a patient has non-cardiac chest pain, so in that case, a patient should be referred from the appropriate places to have the proper treatment of this patient. So actually, this is the way how we can actually treat or evaluate a patient with chest pain actually. And there may be some other causes of the chest pain, like mitral valves. There may be aortic dissection also that can cause the chest pain. And so these are the common causes of chest pain. So we have to go through this way to find out the exact causes of chest pain actually. And this is the way to evaluate the chest pain. So thank you. Genesis Online University, thank you, Dr. Tariq Kamal, for arranging a session to evaluate the chest pain also. So thank you very much.
Thank you, sir.
So I think we can stop here today. So
Yes, sir.
we have to meet in the next class also, inshallah.
Yes, sir. Thank you, sir.
Most welcome.